So, I'm going to talk today about, how is the CF registry important to our center and to the national care of CF patients. And I chose a theme this year. Whoever knows me, they know that I love football, so the theme is football. So what is the mission of a football team is to win, right? So what's our mission? Our mission and our goal, and not only us, but the CF Foundation as well, is to improve the lives of people with cystic fibrosis and to have them live longer, but not only longer, but have a great quality of life, because that is very important for all of us. And finish education. When I see a newborn coming in, parents coming in with a newborn, I would usually talk to them about you have to pay attention. These kids have to be, going to school, finishing, going to college, doing everything they wanted to do, and don't spoil them too much because these kids are very cute and they can wrap you around their fingers, and you all know what I'm talking about. So our mission is, as a CF Center and as the CF Foundation expect us to produce, and I have to say the CF Foundation has been instrumental in getting us to do better care. They've been very much promoting teamwork. They've been promoting that we need to do more, and I'll show you with the CF registry data. So when I do a lot of site visits, so I go to other centers and I see what they're doing. And the mission of the foundation and of every CF center as well is to provide excellent care, but also to do research. Research could be quality improvement, could be multi-center studies, which we approach you and ask you to participate in. It could be somebody starting a project like we do ourselves, or it could be basic science. So it could be any sorts of research, but you need to be doing research. And then also teaching, because we need to always teach the next generation. So we really need to make sure our fellows know about cystic fibrosis. We need to make sure medical students know about cystic fibrosis, because who's going to pick up after that? So we are focusing very much on teaching, but not only the medical staff, but nursing, respiratory therapists, physical therapists, general public. I mean, they need to know about cystic fibrosis. And also, we collaborate with the Cystic Fibrosis local chapter for that. So, requirement for a football team. We need the football coach, and we need the players, and we also need the ref. Sometimes we have problems with the refs, but generally we need them. So, we need the CF in the CF center itself. We have to have a center director to help move things around. We have to have associate center director, which I forgot to introduce today. We have CF center coordinator, and we are blessed to have two CF center coordinators. We have, and in adult as well. So in pediatrics, we have Donna Ginnick is our long-standing coordinator, but also now we have Kathy Enox as well. So we have a social worker and a nurse. And in the adult side, we have the same thing. We have Ronnie Downer and Katie Hall. Both of them are also coordinators. So that adds strength to the function of the center. We have to have social worker, to have a nurse. We have to have RT, dietitian, respiratory therapist, physical therapist, research coordinators, so I won't forget you again. And the research coordinators are very important because they help with research, of course, and the better shape I'm in is because of my research coordinators. So if you have good research coordinators, you have good center, and you have good data coming out. We have psychologists, and we're blessed to have psychology. Not every center have psychologists. And pharmacists, we have one in our clinic, and I know on the adult side have it as well. And we have involvement from subspecialty. The most common subspecialty that we need help with is endocrine and the GI. And we actually, in pediatrics now, I have two junior faculty that are very involved with me in getting into cystic fibrosis. So we're starting the process. And I know on the adult side, they have more senior people actually involved. So, go team, right? So what's the CF Foundation Registry? What is that? This gives you the history of how the CF Foundation, kind of started with the registry. And Bob, Dr. Bell, is very aware. He lived through most of it. So we started in the 1960. I said most of it, not all. So in 1960, they started with the CF Foundation, and they started saying, well, we need to have a registry of some sort. So the data was limited, but it was a registry. And it was paper format. So every year, I started in CF in 1993. And at that time, we still were doing some paper things, and I would send somebody to the medical record to collect the data, and she would see her like in a month, like once a month she comes out. But it was paper formatting, and then we really didn't have feedback from the foundation at that time. And in 1988, we started to have the reports coming up to us. In 94, we started to have the data transferred in floppy. Whoever, the old timers that would remember the floppy desk, I still have some in my office. And then in 1999, we started to have specific center reports. Then in 2003, we start having web-based platform. And then also we were supposed to enter the CF patients' data once a year. We also did not have consent at the time because the data was collected was very limited. And then in the late 1990s, we started to ask more questions, so we started to get the consent. I don't remember the exact year, but we started to have consent form to make sure that patients have the option of participating or not, or families. So right now, we actually enter every time we see the patient. So anytime you come, we have, I don't do it, of course. I have a team of people that do it. You enter the data electronically. You can actually access it electronically on the spot in the clinic if you want to. We usually look at it before clinic. And it's been very, very helpful. So how is it helpful? So first, who is included in the CF registry? It's everybody with CF. And we really like to include everybody because the more patients we have, the more data we get. And that helps us in making decisions and seeing the benefit. So we do usually consent, and we consent them on coming into our clinic, and then at 18, when they're becoming an adult, we usually get the consent as well. And we collect everything. We collect the diagnosis, we collect the clinic visits, all of them. So usually we have somebody in the office like a week or two after the clinic visit, they would enter the data. Hospitalization, home IV antibiotics or IV antibiotics in the hospital, and then there is an annual report as well. My job is to actually keep going, asking them, are we in good shape or not? Are we behind or not? So constantly, but that's all I do for it, and then make sure that things are there. So how does the registry support people with CF? So why are you signing the consent, and why are you bothered with it? And why am I having, two people entering the data and reviewing it? It's because, you get information on a yearly basis on nutrition. How is their nutrition? All the patient, not only overall in your center, but compared to national, and also for each individual patient. Pulmonary function testing, pulmonary exacerbation, microbiology, guidelines. Are we adhering to guidelines? Are the patient coming in 4 times a year as a recommendation from the foundation? And we do a lot of QI work depending on what we are missing or what we're not doing well in. The pulmonary therapy, how are we doing? Are we using enough pulmozyme? Are we using enough hypertonic? So that helping with that as well. Modulator, that's the ivacaftor and the lumicaftor or combination, or the ivacaftor by itself. Complications, how are we doing with complication? How many have diabetes? How many have other issues? And then there is a lung function compared to nutrition, which I'll show you in a little bit. So this is kind of, shows you kind of some of the area that we usually get, and it's practically what I talked about. But it comes in a really nice report. You can print it, you can look at it. So how many CF centers are in the country? There's a lot. So it covers all the country. There is CF center in every state, at least one, but some states have more than one. Like in Michigan, we have 5. We actually have 4 and an affiliate, but consider them 5. Which is really good. There is even one in Alaska, which I volunteer to go visit frequently, but they won't take me up on my offer. There is one in Hawaii, too. Who is followed in the registry? So when you look at the CF population, there is about 34,000 CF patients in the country, looking at the statistics. There is about, not everybody is followed in a CF center. So you have about 90% of the patients are followed in CF centers. And out of the 90%, most of them are really registered for the registry. So very few are not, which is great. We really want everybody to be registered. And why are some CF patients not seen in CF center? These are the adults, or some people are stopped coming to clinics, or people that are living in a remote area that cannot make it, so things like that. So what are we learning from the registry? What we're learning is that, I know, I know what my data is. I know what the patients are doing. I can tell the family, how to do better quality of care for CF. But then the family is coming to me and saying, well, but I can tell you about living with CF and my patients. So I'm thinking that everybody should be 100% adhering. Well, and then there is real life. So it's kind of a combination between what I can offer them as a physician and as a medical team, and what they can teach me and tell me about what they are doing on a daily basis. And then having the happy medium. And the CF Foundation has been very active recently in getting patients' input. So it's very important to keep patients involved. There is a consortium that the CF Foundation is supporting called Success with Therapies Consortium. And it's not really, it's adherence, but we don't like to call it adherence, I guess. So, but it's very, very effective. We meet regularly. We come up with ideas of how to improve adherence by working with patients, by working with families. So this is the thing. It's a team effort. So there is a change in the CF demographics. So we have a lot of changes. Like in 1986, there were only 4,000 people with CF that above the age of 18. Look at it now. We have close to more than half of the patients are above 18. So this is really changing. So adult pulmonary are picking up. They're doing a lot more. They're seeing a lot more patients. They're providing excellent care. And as Dr. Simon said in a conference before, is that soon we're going to be starting talking about geriatric care for CF patients, which would be awesome. So what are the adults doing? This is all information from the registry. I wouldn't know without the registry. So you see that, a lot of them are graduating from college. A lot of them are employed and married, living, or living together. And when you compare it to normal population or population that do not have CF, you can see that, the yellow is the not CF population. That you can see that the adult with CF are graduating college even more than the non-CF patients. You can see that the student or employed is even better, and then married or living together. So it's important to show us that, so we can provide counseling, so we can help with, especially the young kids, we can help them in that regard. So another thing that we learned from the registry, what is the predictor of doing well or not doing well with CF? And we know from this, and I'm sorry, I don't have a pointer, but you can see, like, just starting up and going down, is that, there is, if you're, so 0 is the middle line, and then you have it, if you are in the right side of the curve, that's good. So you can see if you're the right side of the curve, you can be pancreatic sufficient, which means milder disease, or you can be, your weight would be good. So remember, we always push for weight and BMIs and constantly talking about calories. So if your BMI is above 50%, your chances are better as well. And then also staph infection is not too bad. You do a lot worse if you have cepacia, which we're very lucky we don't have that many in our center. So this kind of, again, show us from the registry how to benefit from the data we get. The other thing is looking at the new modulator, the medication. I'm not going to talk about it too much, but when you look at it, you can see that if you're class 1, 2, or 3, your information is probably, you're going to be sicker than the one if you're 4 or 5. So, and that compares to your age of diagnosis. Now it doesn't really matter because we do newborn screen. But FEV1, your pancreatic status, and Pseudomonas is usually worse in the first 3 classes of mutations. And a lot of you guys know what mutations your kids have because we've been doing a lot of it. So more information. Pulmonary function is affected by early life nutrition. So if you are nutritionally are doing well early on in life, then your lung function is going to be well. And this is the cycle we always talk about, that, you know, and then if you're nutritionally not doing well, then your lung function is not going to be as well. The lower the lung function, the more pulmonary exacerbation you have. We also know that. And then with each pulmonary exacerbation, your baseline FEV1 might not go back to baseline. It might be a little lower. So you might have a new baseline. So it's good not to have exacerbation. So, you know, other thing is, okay, we do studies. We do, and we look at it, and we know that, you know, patients do better in the studies, but how about real life? I mean, are they really doing as well as they did in the study? So this is another comparison that the registry did, is that, or does regularly, is that looking at clinical trials which are very structured. Don and Marissa are on the patients all the time, making sure they do their things. Adherence is quite high versus real life, which is real life. You know, things can be forgotten or less frequent. So when you look at it, you can see this is the study patients, and then the study is the yellow, and then the patient general registry data is the white, and you know, for both sides, for both medications. So you have, this is ivacaftor, this is ivacaftor, lumacaftor, and you can see that actually for FEV1 they did better after they done with the study. So the improvement was actually higher, which is very encouraging. So that's something that we learned from the registry. So now we're going to talk a little briefly about our center data compared to national. So I have a problem always with the babies less than 2 years old. They just don't listen to us, and they don't gain weight as they should. We try very hard. Poor Courtney and Sandy's been, you know, wrecking their brains, trying to get them to gain weight. So 1 year you're up and 1 year you're down, so we're working on it. So there is a new project we're working on right now to see how we can increase it and help it. The numbers are also small for the kids younger than 2. But our data is the red line, the green is the average, and the blue is the best 10 center. Our goal is to be best 10 center in everything. There is no single center that is best in all categories, so just keep that in mind. So the BMI is really a nice story that we have, that we started in 2007 working on it as a QI project, and since then it's been steadily above the average. So, but again, we want to pump it up a little more. So again, Courtney and Sandy are doing a project right now that they're going to be working on to try to improve that as well. So the point is, like, don't settle. So if you're doing well, try to do better. So this is really the message that we are doing and keeping in mind. So BMI for 20 years and above, so in the adult side, and you can see this is getting better as well. So, but you know, it's a better 1 year. I mean, all you need is a couple of kids lose some weight and it drags your data. But this is overall, we're doing good, and it got better last year. And it got better last year because the adult side got better coverage. They actually got better coverage of dietitians last year and social work, which is amazing and really good. So this is FEV1 for 6 to 12. And to tell you the truth, it's really kind of give us all heart attack when we saw that now we're average. So we are working on it. We are asking the hospital. So if you look at this, is a 6 to 12, and our red line is our number, and we're now close to average. And if you look at the 13 to 17, look at 2007. That was great. We were like the best center in the country, and now we're a little above average. And then the 6 to 17 lumps together. So that information was reviewed by our chair and our director and a lot of people in the hospital, which I usually do. I would send it to them. And our pediatric chair actually wanted to have, help out with that. How can we improve it? So we're trying to get more, coverage from PT. We need to get more coverage from RT to try to increase and improve the airway clearance. So this way, maybe that will help it as well. So that's something that we're doing. We reviewed our data, see who needs to be on pulmozyme and hypertonic and everything else. And we have a process in place. So I'm hoping by next year, the data will be a lot better. So this is for the adult side, and their data as well is above average. So this is the other very important project that we've been working on, and this is adhering to guidelines. Are the patient coming in 4 times? If it's a baby, we usually bring them in every month. But if it is above 1 year of age, they come in 3 times a year. And are we adhering to that or not? Having 4 clinics, 4 cultures for patients 2 to 6 year olds. And that's getting better. And I tell you, it's getting better because parents are aware. A lot of the time they would call and say, wait a minute, I don't have my clinic visit. Usually we give you a whole year of appointments. And sometimes if they don't have the last one or whatever, they call us. So parents you guys have been awesome in calling us to make sure we get the 4 times a year in. But also our secretaries have took it upon themselves to actually run the list, and whoever doesn't come to clinic because they forgot or they canceled or whatever, reminders. So, and we are willing to see them, as soon as we can. So this has been a joint project from all the team members. Nurses helped with it. We all, as physicians, helped to accommodate patients, and it's been getting better, and it's continuously. This is for the 7 to 17 as well, is getting better. And then this is for the adult, which sometimes forget to come to clinic. And this is, we all are, forged for greatness. We want it to be great. We want it to be best. Every center in the country is trying to be the best center ever. And, you can just work on it to get where you are. So that is very important. So this is a neat slide which shows you where you were 10 years ago and where you were at this last year, like 2000. So it's a 10-year data. So there is I have a pointer, but it's not here. So on the line that is, you can see a little red dot. This is where our data was 10 years ago, and then the check mark is now. So you can see that our BMI is improving. You can see that our FEV1 is improving from 10 years ago. And this is for the adult, and as well, the adult are, they're in the middle, and now they're up as well. So generally, this has helped us with the progression. Are we in the right direction, or are we not in the right direction? So that helps us keep in shape as well. So, it's important to partner and to create the change. So we have the care centers, we have the people with CF and families, we have the CF Foundation, which is very supportive, and we have the patient registry to help us out. And all of that translates into better care of our CF family. So it's very important to all work together to go where we should be going. And the goal is to go to the Rose Bowl or to be one of the top 10 centers. So thank you.